thinking, they just don't get it? Or search for health advice online, but you can't understand it? Felt unheard? You're not alone, and you found your solution with Health Hour. Every Saturday at 11 a.m., this is your space where Caribbean and African healthcare professionals speak about health with a focus on Black people. We tackle the topics that keep you up at night: mental health, chronic conditions, preventive care, sexual health, men's health, women's health, heart disease, and much more. All with the cultural context that matters, because our Black doctors understand the unique challenges we face. Here is what you can expect: real talk from doctors who look like you and get it, lived experience testimonies, practical advice, illness prevention and management tips, and a space of understanding without judgment. You also get to ask questions. Your questions drive the conversation. Health Hour, where community meets Black health expertise.
Good morning, everybody. My name is Dr. Lizzie, and it is a pleasure to have you joining us on this Saturday morning to learn about ovaries. So we've got a real treat for everyone. But let's start off by checking in. How's everyone doing? How's it this Saturday morning, this cold Saturday morning? Tell us where you are joining from and what some of your plans are for today. Let's put them in the chat. I'm joining from London, North London, and it feels about -3. I've got a hot cup of tea. I've got someone from Leeds, a beautiful city of Leeds, they say. I hope that's an invite as well. Salford. And we've got Miss Natalie here with us, and I know she's joining us from London. Manchester. And I'm hearing it's pretty sunny in Manchester. So if anyone's at a loss of something to do or where to spend the day, it sounds like Manchester might be a place to try and quickly get down to or up to. Cheshire. Someone's going to the theatre. Would you mind sharing what you're going to watch? So this is a real treat that we have in store for everyone this morning. So just before we get started, there's still time to share the link with a friend, with a family member before we get going. It's a wonderful world. So that's it seems like it's planned for the theatre trip. A Christmas film. Gosh, it's 22nd of November. I wonder how everyone's doing with their Christmas planning, with their gift shopping. I haven't really got started yet. I've got a note page full of gifts that I want to get for people, so it's probably time that I start buying them. So we do this health hour every Saturday. And I know we've had a range of topics, aging and the menopause. Today we've got ovaries, so we'll get started soon. Just let a few more people join, because this is going to be great information and you don't want to miss it. So I'm going to start by giving us a little bit of a taste of the person who will be speaking to us today. She is an award winner, multiple awards winner, and she won with the Black Healthcare Awards for 2025, the Women's Health Practitioner Award. She has over 25 years experience and she works in one of London's top hospitals in Chelsea and Westminster. We have got Miss Natalie Nunes, who is a leading gynecology consultant in the UK. Her area of expertise covers so much, including ovarian cysts, fibroids, postmenopausal bleeding, early pregnancy, endometriosis, painful periods. So if you have got questions about any of these things, please bring them to us. We're going to have some time at the end for a Q&A, and this is the time to get some questions answered from a leading gynecologist. So please make the most of this. If you've got questions, get them onto the chat. Period pain, high risk early pregnancy. So I work in A&E, I'm an ED doctor. These are the sorts of things that we see through A&E, and then I will often be referring to the gynecology team, which will be led by someone like Miss Natalie. So these are, if you've got questions, which I'm sure many of us will have, this is the time. So we are so lucky to have her joining with us, teaching us today. So I think we're going to get started. Miss Natalie Nunes, please, let's hand over to you. Thank you.
Thank you very much. And thank you, Khan, for inviting me to share. And thank you, everyone, for joining us today. I'm very excited to talk with you all. So I will be talking to you about ovarian cysts and then leading on to ovarian cancer. So I'm going to be talking about, first of all, what is an ovarian cyst? What types are there? How fast do they grow? What are the common symptoms? What are the risks? When you should seek help? The questions you need to ask your doctor, the pivotal important things to help you decide what you want to do about your cyst. And then I'm going to talk a little bit about ovarian cancer itself. So I have been introduced, but what I also wanted to add is that I did a MD research degree at UCL on ultrasound and ultrasound diagnosis of ovarian tumors. So, and I did that for 3 years, and ovarian tumors are really important to me because it's an organ that is vital to us, but it's also hidden. So things on the cervix or things from the inside of the womb usually declare themselves, and they're ways to screen, but ovaries are a lot more tricky and a lot more difficult, but yet still so important to us. So what is an ovarian cyst? So the first thing is, well, what is the ovary? So my background is a uterus, fallopian tubes, and an ovary. So an ovary is what carries all your eggs, which become, with fertilization, a baby. The fallopian tubes dangle over them to pick up the eggs, to carry them along the tube, and then the menstruation happens from the inside on the lining of the womb. So the ovaries are not an external organ, but they are slightly open via the tubes and the uterus to the outside. Now, an ovarian cyst is when the ovary has something that has caused a collection of fluid inside of the ovary. Most of them are benign. They're often related to the menstrual cycle. But some benign tumors can also be solid. So we say ovarian cyst, but we really should say ovarian tumor. But tumor is such a scary word, so we still call it ovarian cyst, but it can also be solid. So common types of ovarian cysts. The most common type of ovarian cyst is actually a functional cyst. And this is something that could happen every month, any month. What happens is your ovary goes through a hormonal cycle where it prepares an egg for ovulation when you're a premenopausal woman. And sometimes if you don't ovulate, or one of the other eggs, follicles get a little bit bigger but don't release an egg, then it can form a functional ovarian cyst. We call it functional because it's part of the normal cycle, but stopping at a particular point. Sometimes the cyst can cause you no problems at all and you don't even know it's there. Sometimes they can cause some problems, and then they usually go on their own. Then we've got dermoid cysts, and these are very slow growing cysts. They can get a little bit bigger than the functional cysts. So the functional cysts tend to be less than 5 centimeters. A dermoid cyst can be anything from, half a centimeter to 20, 25 centimeters. This is the type of cyst that can have anything inside of it because it grows from the cells in the ovary that contribute to making your eggs to make your baby. So it can have anything because the cells have the potential to make anything. So these are the ones that classically have fat tissue and hair. It could have bone, it could have teeth, it could have any part of a human tissue inside of it. But classically, it has fat and it has hair. So if your doctor tells you, oh, it's got hair inside of it, you know what type of cyst they're talking about. Then we have endometriomas. So endometriomas are a feature of endometriosis. And endometriosis is when you have tissue that's similar to the lining of the womb found in other organs. They can be found on the outside of the uterus. It can be found on the side wall. It can be found over or inside the tube, and it can be found on the ovary. When it's found on the ovary, every time you menstruate and bleed from the lining of your womb, you can also bleed inside that spot. And then it can get bigger and bigger, and then it has old blood inside of it. And that's an endometrioma. We tend to call them chocolate cysts. So if they say you've got a chocolate cyst or a cyst with old blood in it, not fresh blood, but old blood inside of it, that is endometrioma. And that at that point, you need to be considering, are there any other features of endometriosis that you need to know about? Then there are cysts called cystadenomas. These can get very, very large. Okay, they can have clear fluid inside of them, or it can have mucousy fluid inside of them, and they can get quite large before causing any symptoms at all, before someone realizes it's there and then needing to have it removed. And then we've got polycystic ovaries, and they're called polycystic ovaries, but they're not cysts. So those same follicles I spoke about that can cause functional cysts, you have a number of follicles in your ovary at any one point in time. And then when a hormonal cycle happens, one becomes bigger to become the functional cyst or to ovulate. And if you're not ovulating very regularly, or basically if you've got many follicles visible on your ovary, then that is what polycystic ovaries is. That's what it is. So it's not cysts, but it's follicles, and they're eggs, and it can cause other kind of problems with your hormones and things like that, but they're not true cysts. Good. So how fast does cysts grow? So they can actually start quite slowly, and then they can get faster as they get bigger. But generally, functional cysts, they don't grow that quickly. They happen over, a cycle, so 2 to 4 weeks, and then quite often they will disappear on their own. They may disappear with a bang, which I will tell you about, but they often disappear on their own. You don't usually ever need surgery for them. And we can talk about the treatment for that a little bit later. And then dermoids, the ones with the hair and the teeth. These grow very slowly, about 1 to 2 millimeters per year. So sometimes you see a small one and you get worried about it, but actually it's unlikely to give you any major problems. You may get away with not ever needing to do surgery for it if it's very, very small. And then you can keep an eye on it every couple of years because we're talking about millimeters here. And then we have endometriomas, and these tend to grow gradually. So every time you menstruate, there is bleeding in the cyst, and so it slowly grows over time, which is why your doctor may suggest using something to stop you menstruating until you're trying to get pregnant, because if you stop menstruating, we believe it stops the bleeding in the cyst as well, and therefore helps to slow its growth. Cystadenomas, these may grow faster when they get quite large, because if you think about a 2 mm cyst doubling in size, let's say it becomes 4 mm, but a 10 centimeter cyst doubling size will become 20 centimeters. So it feels like a bit of an exponential growth, because as it gets larger, there's more of it growing, and therefore the growth begins to accelerate. Good. So when should you be concerned? If you have persistent pelvic pain, if you have bloating or fullness, and if you've got changes in your period. So if you were somebody, which is why one of the things I really encourage women to do is to keep track of their periods. Use an app, use your calendar, keep a track of your periods, because if there's a change in your periods, you want to know. So if you were somebody having regular monthly periods, and then all of a sudden you realize, actually, I'm having really long gaps between your periods, or the gaps are getting shorter, or you're bleeding for longer, or you have a long 3-week bleed, and those sorts of things, that is something that a cyst could be contributing to, and that will suggest that you need to be investigated. Pain during sex. Ovarian cysts can do that, particularly endometriomas, because of the associated endometriosis in the other areas in the pelvis, but also other cysts can do that because of the pressure on the cyst. Infertility or compromised fertility, ovarian cysts can do that. They may do that by preventing ovulation or compromising ovulation, or it may be affecting the tubes with the pressure of the cysts. And basically, any persistent cyst should be investigated. Doesn't mean it needs to be removed, but you need to know about it, and you need to know what is the plan for this cyst. Okay, are we leaving it alone? Do we check it again in 2 years? Do we check it again in 2 months? But it should be investigated and not completely ignored. So, ovarian cysts in Black women. The rates are actually similar to other groups. There is an underdiagnosis of endometriosis, or a delayed diagnosis of endometriosis, because we do know that pain in Black women can be ignored and minimized. So there can be later detection of pain conditions, and therefore of endometriosis. And quite often fibroids may coexist, and there is a tumor on the ovary that's benign, that looks like a fibroid, and is quite similar to it. So these are all conditions that can be happening at the same time. Ovarian cyst accidents. Interesting terminology. And it refers to a painful condition that your cyst has caused. And there are 3 types of ovarian cyst accidents. The first one is rupture. And this is when I said that the functional cyst may go with a bang. This is that bang. It's a sudden, severe, excruciatingly sharp pain, doubles you over. You can't move. Yes, I've experienced that. You can't move, and then it slowly dissipates. By the time you can get to your phone to call for help, it's actually getting better. And then you realize, oh, it's going. Okay, you're fine. And that was probably a cyst rupture. And so it causes that sudden excruciating pain, and then it all just settles down. You don't need to do anything about it. Sometimes by the time you go to the emergency department and they do an ultrasound scan, all they see is a little bit of free fluid, nothing else. Your pain is getting better, and you're discharged. And you're not being dismissed, but it's that it's already resolved itself, and the fluid will just be reabsorbed. Then there's hemorrhage. So you can bleed into the cyst. And that will tend to cause a sudden onset of pain, perhaps not quite as excruciating as the rupture, or quite as sudden as the rupture. But sometimes bleeding into the cyst can then cause the cyst to rupture, which can then sometimes need surgery to stop that bleeding because it bleeds into the cyst. And if it stays in the cyst, the bleeding will stop. But if it ruptures, and then the bleeding may continue, and so surgery may be needed if you have both a rupture and the hemorrhage happening at the same time. And then the last one is torsion. So torsion is when the ovary twists. So the ovary has a little pedicle here and it has another little pedicle there. And they're quite long. And so when the ovary gets bigger, sometimes the ovary is meant to be a little bit mobile. And so when it's small, if it twists, it can just spring back into place where it was before. But when it gets bigger with a cyst, sometimes when it moves, it can't spring back. And if you twist on the pedicle that provides the blood supply, initially what you do is you block some of the blood vessels and you begin to get a throbbing pain. So the pain often is throbbing, then achy, and sometimes you can get the pain and then it can settle because the cyst and the ovary goes back to its original position, and then goes back into the twisted position again. And so, but if it becomes throbbing and then constant, there's vomiting, you need to get to hospital. This becomes a surgical emergency. Your doctor needs to consider if you need surgery, because if this isn't untwisted back, that ovary can die. And so this is the one that's the greatest surgical emergency, apart from the rupture and hemorrhage together, because you continue to bleed. But if that isn't untwisted, the blood supply can be the pressure on it can stop, and then that ovary can die. So really, really important to come into hospital for that, especially if you know yourself to have a cyst and then these symptoms start. So, what tests do we do for ovarian cysts? So, a pelvic ultrasound scan is the number one test. We can examine you, we can do blood tests, but an ultrasound scan is the most important one. It tells us what type of cyst it is, what are the features of the cyst, what size is it, which ovary is it on. It lets you know that, okay, mine is on the right-hand side. If I get pain on the right-hand side, that could be my cyst having a problem and I need to come in. You can get a lot of information. You can get whether it's moving or whether it's stuck, whether it's endometriosis, whether there are anything else going wrong inside of your body. Then there are blood tests like CA125, but unfortunately it has quite limited use. And the reason for that, and I know a lot of people love it, but it's not so useful in young women. So women who are premenopausal, it's less useful because anything that disturbs the inside of your tummy can raise your CA125 a little bit. So if you have fibroids, your CA125 can be slightly raised. If you have endometriosis, your CA125 can be slightly raised. If you've ovulated, your CA125 can be slightly raised. If you're menstruating, your CA125 can be slightly raised. If you have diarrhea, your CA125 can be slightly raised. So while if it's very high, it's suspicious of a cancer, that may be a more advanced cancer, and actually the ultrasound scan is quite likely to have picked it up already. Some cancers do not raise your CA125, and it becomes a little bit more useful if there is definitely a cancer and it's used as part of the follow-up to see, okay, this tumor raised CA125 before. This is a way for us to tell if it comes back. So it's a little bit more useful in postmenopausal women, but even then, they can also have diarrhea. They can also have something going on in their tummy that raises the CA125 slightly. So CA125 is more useful if it's very high. An MRI can sometimes be helpful, particularly for very large cysts, that it's difficult to see the whole cyst with the ultrasound scan. And a CT scan is mainly used for cancer, to look for other organs and to see whether there's any spread. So when do you seek an ultrasound scan? Pain. If your pain is lasting longer than you expect, so you've had your period and it was a little bit painful, but the period stopped and you're still in pain, something's wrong there. You need an ultrasound scan. If your periods are being consistently painful, if you're getting pain during sex, if you're having bloating, and if you're having fertility difficulties, those are the times when you should be seeking an ultrasound scan, which your GP can arrange for you. Treatment options. So sometimes we can watch and wait. The functional cysts, like I said, they can go on their own. You don't need to do anything for them unless they've caused a complication. Dermoid cysts as well, when they're quite small, you can watch and wait. The risk of twisting is quite small, especially when the cyst is smaller than 5 centimeters. When it becomes more than 5 centimeters, we tend to suggest considering surgery then, because we're more likely to successfully remove it with keyhole surgery, which is minimally invasive through your belly button if the cyst is less than 10 centimeters. So when it gets to be more than 5, but not quite 10, that's a good time to consider it's time to remove this cyst. And then there's surgery. No, missed one. There's hormonal. So hormonal medication works for the functional cysts, because you get a functional cyst when your hormones are affecting your ovaries and having a hormonal cycle. But if you go on the combined pill where you don't ovulate, then your ovaries do not go through that hormonal cycle, and it reduces the risk of the functional cysts. Then we've got surgery. It can be keyhole through the belly button, minimally invasive, faster recovery, or it can be open if it's quite large, like that picture I showed you earlier of the huge cyst. If you want to get that cyst out intact and not spill the contents inside of the tummy, then that would be open surgery. Good. So the key takeaways for ovarian cysts. Most of them harmless and go away on their own. Early assessment prevents complications. Black women may face diagnostic delay. You need to advocate for yourself. You need to take someone with you to help you advocate if it's more difficult for you. And then discussing the next questions will help you decide what you should do about your cyst. So, ovarian cancer overview. I think I forgot my slide on the questions to ask. Or maybe I have it later on. We'll see. So, ovarian cancer overview. It's much, much, much less common than benign cysts. It's more common in women over the age of 50. Symptoms are often vague at first, so mild aches, bloating, change in bowel habit. I'm going to go through some of the symptoms. And an early diagnosis improves the outcomes. Like I said, the ovary is such an internal organ that the things that give you an idea of what's happening are quite subtle. And that's why it's really important as a woman to know your body, know your cycle, know how you feel, so that when things are a little bit different, you know to get it checked. So, symptoms: persistent bloating, which can be bowel things can cause bloating as well. But if you have persistent bloating, you can see your GP about that. If you're feeling full quickly, then sometimes that's because something is pressing on the stomach, and so you can't eat as much as you used to. Pelvic pain, so low down, abdominal pain. Changes in the bowel habit. Because of the pressure on the bowels, it can change your bowel habit. So it can cause more constipation, or it can cause loose stool. So you can also get diarrhea. And unexplained weight loss or fatigue is also a very big one. And so if that's happening and it's unintended, not, then you need to ask your GP for investigations, and they would not usually resist you on that. So what factors increase your risk of ovarian cancer? So being over the age of 50, the risk does begin to go up. You can't do anything about that. Then there are some gene mutations. So if you have a family member who's had ovarian, breast, or bowel cancer, there is an associated gene mutation called BRCA. We call it BRCA for short, BRCA1 and 2. And usually they will be tested for BRCA1 or 2. And if they are positive, then descendants in their line or people within the close family. So if an aunt had it, and she was BRCA positive, if your mom had it, if a cousin had it, then you can be tested. You can request to be tested to see whether you are positive for BRCA1 and 2. Because if you're positive for BRCA1 and 2, you are at increased risk of ovarian cancer, and then you may consider what we call risk reducing surgery, which means once you've completed your family, whether you want to remove your tubes and ovaries to reduce the risk of ovarian cancer. That is a really big decision to make. If you have it and you want to test your children, the timing of that testing is also a big decision to make. And take your time making that decision. But if you have a family member who's had ovarian, breast, or bowel cancer, sometimes we forget about the bowel, or if they are BRCA1 or 2, you can get tested because that increases your risk, and then you can decide what you want to do to reduce that risk. So that is something you can do something about. If you've had no pregnancies, unfortunately, that does increase your risk of ovarian cancer. And the theory is that you've had more ovulations, and every time you ovulate and an egg is released, that increases your risk. So if you've had no pregnancies, so you've ovulated for every cycle of your life. If you've never used the pill to stop ovulation and you've ovulated for every cycle of your life. If you've had an early first period, so you've had more cycles. If you had a late last period, so you had more cycles. If you had IVF, that produced more eggs and more rupturing or more punctures on your ovary, that increases your risk as well. Endometriosis, unfortunately, does also slightly increase your risk. And so inside the endometrioma, you can sometimes have what we call malignant transformation. So inside becomes abnormal and your cyst begins to look different, begins to grow. And so that is a situation that can happen. And long-term use of hormone replacement therapy, certain types can be associated with a slightly increased risk of ovarian cancer. So what are the things that reduce your risk? Less ovulation, as I mentioned, more ovulation increased, less ovulation reduces. So if you've had more pregnancies, if you've breastfed and therefore your period did not return for a little while, so you were not ovulating, if you've been on the pill, that reduces that risk. Interestingly, tubal sterilization, probably more removing the tubes rather than just clipping them. A really interesting one that reduces the risk of ovarian cancer. And we've noted in our studies that the tube, sometimes ovarian cancers actually start in the tube and then go on the ovary, or it's cells from the tube that implant on the ovary. And therefore, if for any reason you're having surgery removing your ovaries, you should remove your tubes as well, because you can still get a cancer rising there. And therefore, if you have a hysterectomy and you remove your tubes, that reduces your risk as well. Good. So, ovarian cancer in Black women. Interestingly, there's a slightly lower overall incidence. So it happens a little bit less in Black women. But it is often diagnosed later, like many, many things. So even though it's less common, even though you may be low risk, you've had lots of pregnancies, you started your period late, you had your menopause early, you were on the pill for 20 years, even if your risk is low, if you begin to have symptoms, you need to get it checked out, because the later the diagnosis, the less we can do for you. And we're really trying to improve equity in screening. Sometimes it can be challenging to push for screening for like the BRCA genes. Yeah, so we're trying to improve that. Good. So how can you survive ovarian cancer? The earlier recognition is so important. The earlier we find something, when it's in a smaller cyst, when it is detected early, then treatment can be curative, and much better survival, living much longer, with less complications. Finding the right specialist. So we have changed cancer care to, it used to be that any gynecologist would manage their patient with ovarian cancer, but we now have cancer centers, and that's really important. So as soon as there's a diagnosis is made, unless it's very, very early, like what we call a borderline tumor, which can happen in a regular unit, other than that, you go to a cancer center. So it's important that you go there to see the right specialist. It may no longer be your local unit, so it may no longer be around the corner, but it is important to have the treatment with the right team. You need strong support. Your mental presence, your mental, the support you receive, how you feel emotionally, the mind and the body are so tightly interlinked that just your attitude and your mentality to how you are going to tackle this cancer has such a positive impact on your survival. And so it's really important to get that support. I know some people, you don't want to tell family members, you don't want to worry people, but actually you need that support, and you need to decide, who am I going to tell? Who am I going to bring along for my support? And then you need to be informed. You need to know what type of cancer, what sort of treatment, have a diary, note everything down, keep your letters, be informed about your treatment protocol and what they plan to do. If they say they're going to see you in 2 months and you don't get that appointment, you chase them. Don't leave it completely in the hands of the doctors and the hospitals. Everybody does try their best, but really important to partner with them to take care of yourself. Good, your medical team. So the team would include an oncologist, and that's the doctor cancer specialist. Then there's a cancer center MDT, and there are a lot of people in that team. So you've got the doctor, you've got a clinical nurse specialist who is very knowledgeable and very supportive of the care that you need, and supporting you and directing you when you need something. So, for example, helping you decide what to do about the potential hair loss that happens during treatment, or helping you choose whether you want to wear a wig or a scarf or nothing at all, and wear your bald skin head proudly. Like, how do you want to deal with this issue? Then we've got pelvic physiotherapy team members to help you manage your pelvic floor and how it may impact your bowels, and what to do physically to maintain your strength during this difficult time. And you've got the radiologist who's looking at the images to tell the surgeons where the disease is and where it's not, and therefore help decide what the next treatment is. And then you may have a general oncologist who's more specialized in maybe the chemotherapy, and they decide together what drug combination is best for you. So there's a big team, and they are there to support you. There's usually a support line, access to either the CNS or someone else, so that, because support, when we realize that support has such a big impact on your recovery, you need to access what you need. You decide what you need and access it and get that for yourself. Good. Treatment options. So the biggest number one treatment option is surgery. It would be what we call debulking, removing the ovaries, the tubes, and the uterus. For some early cancers, they can just remove that ovary and continue to keep an eye on your other ovary. For the women who are younger, who have not yet had their families, they still want children, If it's an early cancer or what we call a borderline tumor, which behaves kind of something between benign and cancer, you can have one ovary removed and leave the other ovary on your uterus, and you have regular ultrasound scans every year, initially more frequent, but then every year, so that the minute something appears in the other ovary, you can treat it, and then you can use that time to have your family if that's your wish. So surgery, really important. Deciding what the surgery is, how extensive is it going to be? Then there's chemotherapy, and chemotherapy depends on the type of cancer, and it is, usually in cycles. So every couple of weeks you go in, it's in an IV line, you feel really unwell for the 1 to 2 weeks after, then you begin to feel better, and then you go in for your next cycle. And so it can be it's a difficult time. They will give you medication to support things like nausea and so forth. And then things like hair loss, depending on the type of cancer, they can talk to you about using a cold cap to reduce the blood flow to your scalp, to reduce the chances of hair loss, depending on which chemotherapy agents you're having. So all of these things are things you can discuss with the CNS and with your team. Then there's some really interesting targeted therapies that have started. And this is a therapy. So the PARP inhibitors, they actually help kill cells, help them stop dividing. So it's not a chemotherapy, but it's a targeted therapy. And it depends on the type of cancer you have, especially like if it's BRCA1 or 2 positive tumors, these work quite well for it. Then there are also some hormonal therapies that can be used for the recurrent cancers when if it does come back in the future, sometimes medication, kind of ongoing medication, may be required. And clinical trials are such an exciting opportunity. Sometimes we can be a little bit suspicious, but honestly, clinical trials give you the opportunity to access some of the newer drugs. They wouldn't reach clinical trial stage if there hadn't been some effect shown in the lab. And so if this is a potential to be enrolled in a clinical trial, I say go for it. Optimizing your health. Apologies for some of the overlapping of the slides. Optimizing your health, really important. So good meals, meal planning, keeping hydrated, maintaining your exercise, keeping yourself moving, keeping your bowels regular, reducing sugar, which sugar is something that can affect tumor growth. Stop smoking if you do smoke. Manage your blood pressure, your diabetes, your weight, all these things. Because the healthier you are, the better your body is able to tackle this cancer, and also the better your body is able to tolerate the chemotherapy. Chemotherapy side effects. These are the things to look out for in the week after your chemotherapy. So fatigue, nausea, hair loss. Neuropathy is when you can get funny sensations in the tips of your fingers or toes. Sometimes it can be pins and needles. Sometimes it can be numbness. And sometimes, like I mentioned, the cold cap for your head. Some medications are very highly associated with the pins and needles, and sometimes they can use cold gloves to reduce the effects. So there's less of the chemotherapy getting to your fingertips, and therefore less effect on the nerves in your fingertips. Bowel changes, and it's really important to report your symptoms early, so that they can advise you. Like, don't feel you're bothering people. Say what's happening, and then they may say, I can't do anything about that, but they may say, I have something to solve that for you. And that's really something very powerful and positive. Emotional and psychological survival. So not just physical survival, but this is a hard thing There's no doubt about that. But there is support for you. There is counseling. There's support groups where other people can tell you of their experiences and what they did. There's something really quite powerful about a group and a community. There's something very powerful about a community. And when you're in a group of others like yourself, and discussing your experiences, they may be able to tell you things that worked for them that even the doctors don't know because they've not experienced it. And this patient says, well, I'm going to just say something random. I was using an emollient cream on my hands and it reduced my pins and needles. Like, we don't know that, but somebody else who's been through it might have tried that and they would know that. So being in that support group is actually something quite helpful to you. Involve trusted people. You want somebody, your advocate, you want somebody alongside you, whether it's a partner, a sibling, a friend, a child, somebody in your family or a friend who can be your support. Really important to keep track of what's happening, because with all the busyness and all that's happening and the stress of it all, you can forget. Note things down, mindfulness, breathing. Sometimes we're like, oh, what is that going to do? It really does do something. It reduces the cortisol that responds to stress in your body, which then helps your body fight this. So not just your physical, but your emotional and your psychological, please. So, living with ovarian cancer can sometimes be a long-term experience in terms of it can come back, but it's not killing you, but it's just something you're constantly managing. And not ideal, but it can happen. Keep up with your regular follow-ups. Know the symptoms of recurrence or worsening. Keep active, keep healthy. All the other advice about healthiness, mindfulness, eating, activity, support, all really important, and continue to use your community. So, diet, exercise, and lifestyle. So, high protein. So, we need protein-rich foods to help rebuild your cells that are having the onslaught from your treatment. We need iron-rich foods because you can become anemic. You want to maintain your strength. So, not just cardiovascular things, but strength things. So, you will be advised specifically about what is appropriate for you. Sleep, maintain your sleep and your rest. Avoid alcohol, vitamin D. As Black people, people of color, we are vitamin D deficient as a baseline. So you definitely need to be topping up whether you have a cyst or not, whether you have a cancer or not. Vitamin D is really important. Support network, I've mentioned, family and friends, the nurse specialist, the oncology nurses, the physio, dietitian, psychologist, cancer charities. You check all of that out and find out what works for you. Not everything will work for you. Some things may work for you. You may not like a particular group. That's okay, but find your support network. The things to make you seek help urgently, the things that should concern you is if you've got a fever, if you're short of breath, if the pain is uncontrolled, persistent, getting worse, nothing is touching it, you can't get the edge off of it, if the vomiting is severe, if you are bleeding, or if your tummy is getting swollen quite fast, so it's growing, that is something that you should attend the emergency department. So key takeaways: specialist care improves survival, build support, get your support team around you, manage the side effects, look after your health, your whole health, mind, body, spirit, all of it. Look after your health in the general, stay informed, find out, if you hear something about a new treatment out there, Start reading, doing searches and getting information from reliable websites. And you're not alone. You're not alone. Find your community and you can get that support that you need. So I did forget my slide about questions to ask. So I will just read them out for you. Let's find that. One second. Okay. Okay, so the questions you need to ask, and this is about your cyst in general. You need to know what type of cyst it is. Is it a functional cyst? Is it a dermoid cyst? Is it an endometriosis cyst? Because the type of cyst will determine what you need to do about for it. And it will determine, like, if you went for a second opinion from somebody else, you can't just say, I have a cyst. They would want to know what type of cyst in order to give you advice. You want to know how big it is and is it growing? You want to know, does it look benign or is it suspicious? You also want to know, will it affect your fertility if fertility is important to you? You also want to know what symptoms to look out for. I've mentioned some of those in terms of increasing bloating, pain that doesn't settle, all those sorts of symptoms. You need to know what things to look out for. When you should go to A&E. Do you need the blood test? Like, is the CA125 going to be useful for you? Could this be endometriosis? If they say it's a hemorrhagic cyst, like a cyst with blood inside of it, you need to ask them, could this be endometriosis? So is this just a fresh cyst with a fresh bleed inside of it? You want to know, what are your treatment options? So I've mentioned the 3 categories, but you need to ask specifically for your cyst, what are the treatment options? What should I be doing for this 3-centimeter cyst or this 10-centimeter cyst? And if surgery is needed, what type and why are they choosing that route? If they say it's going to be open surgery, well, why? Why are we suggesting open surgery? Could you please explain that to me so you can understand why they're suggesting? And in that discussion, sometimes even as doctors, we kind of just jump on one idea, and then when a patient says, well, why that? What about that? And you're like, well, that might be more difficult because of X, Y, and Z. But if you want me to try that, I can try it. Like, we could try the keyhole, but there's a chance that I may not be able to do it. And then you might get your keyhole surgery. So it's really important to have that discussion with your doctor. Who will perform the surgery? Will it come back? Is this a cyst that could come back? Or is this, it's gone, it's unlikely to come back? If we're not removing it, how are we going to monitor it? Are we going to check in 6 months? Are we going to check in 2 years? And whether you need to go to a specialist, or is this plan fine for you, between you and your doctor? So that's a lot of talking. That's me. Ovarian cysts, ovarian cancer, all my recommendations, and I'm happy to take any questions.
Miss Natalie, thank you so much for all of that information. That was really good. You covered the anatomy, the body, and the emotional, the psychosocial elements of it. So we've had the whole journey from the things to look out for when you first contact your GP, all the way to thinking about your life after you may have had one of these cancers, after the treatment for it. So we thank you so much for all of that.
Right.
Just to be really, really clear, so if someone was thinking they may have a problem with their ovaries, something around their womb, what is maybe the first thing that they're asking their GP for when they get there?
An ultrasound scan.
Okay, so that's really important, everyone. Because sometimes it might be a case to say, oh, do some bloods, and then you leave it there and nothing progresses. So that's really clear. If you think there might be an issue, you're asking for an ultrasound, you're pushing for an ultrasound. And I know sometimes you might see someone once, you might need to go again, but making sure you get that ultrasound is really important.
Yeah.
And I think what's really interesting as well with these ovarian pathologies or problems, sometimes they can be more long-term, something rumbling in the background, and then you've highlighted some of these longer-term cysts, even cancers. And then it could be more acute, something which is take you to A&E, lots of pain,
Yeah.
something like the ovarian torsion of that twist.
Yeah. Yeah.
There was one thing I was wondering about. We heard a lot about cysts and ovarian cysts, something like polycystic ovaries. Where does that link in?
Yeah. So polycystic ovaries are, it's really not the right name, and the whole community is looking to change the name of it because they're not actually cysts. They're just the follicles that carry your eggs. And but polycystic ovaries do make your ovaries bigger. So you can have some of the complications. So you can have a functional cyst that then develops and ruptures. You can have twisting and torsion of your ovary, just your whole ovary, because it's bigger because of the polycystic ovaries. So I included it because it's not a cyst, but sometimes it behaves like a cyst. And so it's still important to know that that is what you have, so that if you begin to get these sorts of symptoms, you're like, maybe it's my polycystic ovaries doing this. I need to get checked and see what is happening with it. And it's sometimes a little bit difficult to get a scan for polycystic ovaries. And so it can't be just that you have polycystic ovaries, but something has changed. I'm having pain with my polycystic ovaries. My periods have become way worse. Like, is something going on? Like, do I have a different type of cyst alongside it? That's a moment to have that discussion about another ultrasound scan.
Thank you. And that's so clear with that information. So, of course, the name polycystic kind of makes it feel like it fits in with all these cysts. It's something slightly different, and you can have different cysts all at the same time. So, even though you might already have polycystic ovaries, when you've got new symptoms, get it checked out again. So, I'm going to go to some of the questions that have appeared
Okay.
as well. So,
Yes.
someone asked, can you still get a cyst if you have had your womb and your fallopian tubes removed?
Absolutely. You definitely can. As long as your ovaries are still there, you can get a cyst inside of your ovaries. And so you won't have kind of bleeding symptoms to look at, but pain or pain with intercourse or or bloating can be some of the symptoms that you can get. And in fact, after you've had surgery, you can get what we call adhesions or scar tissue in the area. And if the ovaries get a little bit entrapped or stuck, they're actually slightly more likely to have functional cysts that can come and go. So yes, even if you've had your uterus and your tubes removed, as long as you have ovaries, you can still get ovarian cysts.
Thank you. And at that point as well, people sometimes think they've had surgery, they've had things out, but they may have left the ovaries inside. So it's been really clear what part of the body we're certainly removing.
Absolutely. I've had too many patients come and said, yes, I've had a hysterectomy. Okay, did they remove your tubes? I don't know. So, sometimes you don't remember because so much is going on. So it's really good to keep your letters or have a notebook, keep track of your health, because when something happens in the future, it's really like we need to know, well, what was removed and what's left. So we know when we're looking at your imaging and your ultrasound, we know what we're looking at and what is going on.
I think one thing that you definitely keep saying over and over again, which as well I want to just say thank you for, is that speak up.
Yeah.
When things aren't quite right, speak up.
Yeah.
You mentioned things like side effects of medication, and sometimes we might want to go through things almost by ourselves. We don't want to worry anyone. We don't even think there might be a solution for it, so we don't say anything. It's
Yeah.
always better to speak up. And
Yeah.
right, sometimes they might not necessarily be able to solve it, but there
Yeah.
may be something, or they might point you somewhere else.
Yeah. Yeah. Yeah.
Someone's asked a question about genital itching, and somebody might have that symptom a lot of the time, all the time.
Yeah.
What sort of things should they be doing?
So genital itching is not, I can't think of any ovarian pathology that will contribute to that. But it's definitely not something to be ignored. So you need to definitely see a doctor about that. It could be a skin change, like, needing to see vulval dermatologist, or it could be a vaginal discharge. It could be something like thrush. It could be it could be a type of infection, or, a skin change. There are a lot of things that it could be. And so when you see someone, they will start with things like infection screening, looking at the skin, seeing, is it just itching, or is there actually a lump or something that needs to be treated or removed or biopsied. There are so many things that can do that. So really important to get that checked out. Don't ignore it. I mean, it could be your not dish, your clothes washing liquid that you're using, that you've changed, or not using cotton underwear. All sorts of things can irritate the genital area. Yeah.
It's one of those things that you might have a symptom which is all the time, or you frequently experience, and you almost normalize it. So
Yeah.
that's why it's so important to have people like you who come and share and educate the
Yeah.
community, and just highlight that these things might not be normal. Better to get checked out and try and get them solved.
Yeah.
You mentioned something about clinical trials, to say that they do exist. Our community might be quite worried about the concept of being involved in a trial,
Yes.
or this idea of experiments. Can you just talk a little bit more about that, please?
Yeah. So when I mean, all the drugs that we use started with a clinical trial. And what happens with when we reach the point of a clinical trial, it's because they've looked at the structure of a drug and they think, okay, this may be beneficial. And then they will test it in the lab first. So they'll put some cancer cells, or they'll put some cyst cells, and they will add this drug to it in a particular concentration or varying concentrations to see, does it have an effect? Then they might do animal trials, love it or hate it. They will often try it in animals to check out things like side effects. What kind of dose do we need? Does it have an effect? And then if it has an effect, then they're looking to see, is it better than the standard treatment, or is it that we should add it alongside the standard treatment? And anytime we do a trial for this sort of thing, it's typically you have the routine stuff, or you have the routine stuff plus this. And if this is going to be, like, quite often, it's something that will either have no benefit or it has a benefit. It's unlikely to be, my treatment is worse off by being part of this trial. So sometimes this is your chance to get access to a new drug that has potentially really positive effects for your treatment. Like right now, we have a trial coming in January for early endometriosis, so superficial endometriosis, when it's just on the skin of the inside. It's a drug that's non-hormonal, and it is something that affects lactic acid. So when you go for a run and your legs are burning from that exercise, that is a buildup of lactic acid. And they found that with endometriosis, there's a buildup of lactic acid inside of the abdomen, in the peritoneal fluid. And so now we're going to do this trial. And so sometimes this is an opportunity to get it. Like, you're not going to get it otherwise. And so it's not, then we're not going to get permission to do a trial and offer this to anyone unless there were certain safety parameters in there. And so I really do. I mean, I know some people who even kind of go around saying, I'm looking for any trials that are treating this condition because I've tried everything that's out there. It's not done anything for me. And now I'm looking outside the box. So I think you need to be really, really open to it. There are a lot of safety checks in place to make sure you are protected. And clinical trials are really a good opportunity to access things that you may not have access to otherwise.
Thank you so much for that explanation. And hopefully there's a level of reassurance there that if you are being offered involvement in a clinical trial, certainly something to consider. It's not nilly-willy. This is science, and this is about trying to give people the best outcomes.
Absolutely.
There's also something that's in your bio that I just wanted to know if you wanted to speak a little bit about in terms of the digital solutions that you are working on, that you are involved with. Tell us a little bit about that.
Yeah, I think I like to gather solutions from every possible place. And I think there are a lot of digital solutions out there that we can utilize. So one of the ones that I brought to my unit was using virtual reality headsets, along with my colleague Lauren. She's a research, she's a research midwife, and we did it together. And we use virtual reality headsets for patients who are having awake procedures for miscarriages operations. And we were like, when you're having a miscarriage operation, this is a very emotional time. And we know that emotions are linked to pain. So, yes, you're feeling pain, but if you're really unhappy and sad and anxious, the pain experience is going to be worse. And we wanted to see what can we do to reduce that. We can never take it away. This is a horrible time for this woman and her partner. So what we want to do is make it easier. And so we introduced that, and it was so well received. Pain scores were less. Patients were happier. They could still hear. They could still understand what we were doing. And it really improved their care, and it gave them options. We still give the injections, the tablets, we now have a gas that we use. We offer you everything. We've got lights on the ceiling that you can look up at, really calm. We play music. Like, we want to make this as unhorrible as we can. And we have something coming up. There's something called a Nettle device. It it has like little electrodes, and it's a new thing looking at how it reduces pain. And they're looking at trying it for endometriosis pain. They're looking at trying for PMS and PMDD. And then we're going to look at it for perimenopausal symptoms. That's a gadget, and that can potentially improve symptoms. And I'm like, yeah, I'm happy to, like, yeah, bring it on. So we're in talks with the company right now about doing a study, because it's like, what else could we use it for? Like, okay, you started using it for this, but what else could we use it for? So I think whether it's something psychological, whether it is something physical, like exercise and improvement that exercise gives to you, whether it's about support, whether it's about medication, or whether it's digital, I think all these things we can bring together to provide support and healing for ourselves.
Miss Natalie, thank you so much for speaking a little bit about that. And it's great to hear the passion in your voice. And you know what? We've got our Black doctors who are working at the forefront of this technology space and advancement and trying to make things better for all of us. So it's great to hear. We're going to leave it there. Thank you for your time with us and for answering these questions. Really great to have you. And even me as an A&E doctor learned something new and some reminders for me. So thank you everyone for joining us. And I'm going to hand over to Sam.
Hello, everyone, and thank you very much again, Dr. Lizzie and Dr. Natalie. It's been a great session. I'm just going to quickly go through the closing slides, just to let everyone know what's going on within Khan, and just stay tuned. I shall not take too long. Also, thank you guys for staying on, past the 12 o'clock to listen further on ovarian cancer. We deeply do appreciate that, and hopefully this session has provided you with ample information that you could go away to share with your friends, family, and feel a bit more reassured that you know how to spot the signs of ovarian cancer going forward. So next week we'll be talking about blood cancer with Dr. Noma. She will be presenting with us alongside another doctor, so it's going to be a special session alongside Blood Cancer UK. So please feel free to tune in. Same link, same time, and we'll look forward to seeing you there. Next slide. Oh, sorry, my slides are jumping about now. Ooh, as you guys know, it's getting cold, which also means one thing: winter is slowly creeping up, and I guess it's November now, so I guess winter is here. So we have the upcoming carol service taking place at the Manchester Cathedral on the 9th of December. It's a free event. Please do come with your friends, family. Everyone's welcome. There's going to be lots of, Christmas carol that's going to be sang. I'm going to be bringing my best voice because I expect to be singing. Not on stage, just as part of the as part of the crowd. It's going to be candlelight readings, and there's going to be much more going on. So please do feel free to come down, register by scanning the QR code, and bring your friends, family. All ages are welcome, all religions and all beliefs are welcome. So please come down to the Manchester Cathedral on the 9th of December from 7 p.m. to kick off Christmas with us. We have the Green and Arts service, Green and Arts Wellbeing service available at Bolton and Stockport. So at Bolton is available every Wednesday, and at Stockport is available every Tuesday. If you'd like to take part in this, please do contact Lola at Green and Arts Wellbeing at con.org.uk, or also scan the QR code. Within the Green and Arts Wellbeing, there'll be things like crafting with your hands, finger painting, all sorts of arts, going outside and exploring the nature, going through there's a garden there that you can visit and utilize the connection between yourself and earth just to feel a bit more grounded. So yeah, Green Arts is a great service, and it's a great way to improve your mental health and improve your connection to the outside world. We do have the BHIP service available in Enfield. If you'd love to be involved with this, please scan the QR code, so where you can get accredited sessions where you learn how to be a bit more culturally appropriate in engaging with our community, which is something we believe is very important. Within our community, within the Black community, we have various beliefs of various cultures. So it's good that those that are providing help and health, those that are providing help, health information and care for us, understand how to engage with our community and engage with people from various backgrounds. So this is a accreditation that's available. Please do scan the QR code to learn more, or you can contact bhip at enfield@con.org.uk. We have the Safer Homes Project, which is a project that launched in August. It's going on for about a year. So this is a project that's happening across Croydon, Lambeth, Lewisham, and Southwark, where we are offering free carbon monoxide alarms and checks. We're also providing guidance for the energy bills due to it's winter season, and the energy bills will be going up due to how we're using our energy to stay warm. We'll also be providing ways that we can help each other maximize our income, and also advise people on how to be registered on the Priority Service Register, which is a free service where you register on there, and if there's going to be an outage, if there's going to be any issues, that you are notified prior to that. There are some categories for being eligible, but if you visit the website and www.thepsr.co.uk, you'll be able to learn more about that, or you could just easily email saferhomes@con.org.uk to learn more about this. Here are some of the locations that will be within Lambeth, Southwark, and Lewisham, and the opening times. And if you have any more information, if you need any more information, either email us or look out for more information on our socials. We have the Boys Club and the Girls Elite Club. This is just a young people's club where we help, keep the young people on the right path, give them something to do where they can connect with other young people, be inspired by local young leaders who take them through various things, from going to the arcade with other people, or taking part in sports activities, just something to keep them connected and active. When I was much younger, I did partake in these clubs with my friends, and it helps me grow into a good individual, and an individual that likes to spend some time outdoors and improving my confidence and being strong. So I encourage anyone listening to this to sign up your young people that between the ages of 10 to 18, either for the Boys Club or the Girls Elite Club. Scan the QR code as well to register or to find more information on this. So within our services that we provide here at Con, if you are looking for some support, we do have a DVSA support service. We have an advocacy support service. If you are having any home office issues, any immigration issues that you want to know more about, or want to be a bit more informed for yourself or your network, please do reach out to us. We do have a family advocacy session and a legal drop-in session. Within the legal drop-in session, I think we handle things like employment law and just understanding, housing law, all those kind of things that you may not know or you may want to be, more updated on. So please do feel free to contact us at advocacy@con.org.uk. I'd love to say a big thank you to everyone that's tuned in today, whether you've tuned in on Zoom, YouTube, LinkedIn, Facebook, you're watching this live, or you're watching this in a few weeks' time or in the future to come. We do appreciate you spending this time with us and learning further about your health, especially today's session on ovarian cancer. I know I've learned a lot. I don't have ovaries, but I know people that have ovaries, and I feel a bit more, reassured on how I can encourage them to take care of themselves or seek the right help by going to the GP whenever you have an issue. I think that's something our community doesn't always do. So it's good that we have a platform like this where we can learn and feel encouraged to speak up for our health and speak up for the ones around us. So thank you very much for tuning in with us. Hope you have a wonderful Saturday. And that's goodbye from me and the Calm team. Have a wonderful day.
And that's our for today. Whether you joined us on Zoom, Facebook, LinkedIn, or YouTube, thank you for making the Health Hour part of your Saturday. We hope today's session gave you the right dose of health wisdom that you can share with your friends and family. When we share knowledge, we strengthen our entire community. Mark your calendar. Next Saturday, same time. Got a topic in mind? We want to hear from you at health@can.org.uk. Health Hour, hosted by the Caribbean and African Health Network.